academic lecture series that we are conducting under the aegis of Haryana AOI for past 2 years now. And this is our third chapter, which is going on. So today's topic for today's session is the carcinoma of unknown primary with neck node metastasis. And we all know this is a topic which involves the involvement of multiple disciplines. So today we have gathered panelists from different disciplines to get their suggestions, their opinions in managing or approaching such kind of patients. So we have very experienced panelists and a moderator. So first I would be inviting all the panelists, then I will introduce the moderator for today's session. So we start with, first and foremost, we have Dr. Ishwar Singh sir. Sir is an ENT expert in the panel, and he has a special interest in head and neck surgery. Sir is currently affiliated with Maulana Azad Medical College as Professor of Excellence. Sir is ex-Dean and Director of Baba Saheb Ambedkar Hospital and Medical College in Delhi and Director of Indira Gandhi Hospital. And Sir was the ex-Secretary of Secretary and President of Delhi AOI. Sir has over 150 publications in national international journals. He has been an invited faculty and is a great academician. So thank you very much, sir, for being a panelist today. Then we have Dr. Kanika Rana ma'am. Ma'am is a head and neck oncologist at Medanta Hospital. She's a senior consultant there, and she has done her fellowship in head and neck oncology at Medanta, and she has been trained at Sloan Kettering Institute Cancer Center and John Hopkins Center, Baltimore. So welcome, ma'am. Thank you for being here.
Thank you, Rama.
Then we have Dr. Satvir Yadav, sir. Sir is a senior pathologist at Yadav Path Lab, Bhiwani, and he has a special interest in histopathology and has over 41 years of experience in the field. And sir has obtained all his qualification from an esteemed institute of Haryana, PGIMS, Rohtak. I welcome you, sir. Thank you for being here. Then we have Dr. Sheher Awad. Sir is senior consultant and head of Department of Radiation Oncology at Bhagwan Mahavir Cancer Hospital, Jaipur. And he has done his fellowship in brachytherapy from California, Los Angeles. So I welcome Dr. Sheher Awad.
Good evening. Good
Then
evening.
we have, last but not the least, Surgeon Commander Dr. S.N. Singh, sir. Sir is professor and head of radio diagnosis, and he is currently affiliated with the Mahamana Pandit Madan Mohan Malviya Cancer Center, Varanasi, and has special interest in head and neck oncology. So thank you very much, sir, for being here. Now, our moderator, he's Dr. Ravi Shankar, sir. Sir has done his MCH from in head and neck surgery from Tata Memorial Center, Mumbai, and is a senior consultant head neck surgery at Asian Institute of Medical Sciences, Faridabad. He was earlier running FNB program in head and neck surgery at Mahavir Cancer Sanstha, Patna, and has been an invited faculty at many national and international conferences and has many journals published in national and international journals. So I welcome you, sir. Thank you for being a participant today, moderator for moderating today's session and for selecting such a topic. So thank you very much, sir. I invite you all on behalf of Haryana AOI, and I request Dr. Ravi Shankar, sir, if we can start the session.
Thank you, Raman. Thank you for this topic. This is indeed a very interesting topic for all of us in the field of ENT as well as in the field of head and neck surgery. So, as we are short of time, I think I'll start. Before I start, we have to understand what is carcinoma unknown primary. So, what is carcinoma unknown primary? When a patient basically presents with clinically manifest cervical lymphadenopathy, where a primary tumor cannot be identified after a thorough medical history, clinical examination, and a diagnostic workup. There are multiple hypotheses for this. So there were some defined criteria which were laid down to say, okay, this is a carcinoma unknown primary. So there should not be any history of previous malignancy. There should be no history of definitive symptoms related to a primary tumor. There should be no clinical or lab evidence of a primary tumor. And one or more cervical masses should be histologically proven to be carcinoma. So based on this premise, we'll continue our further discussion and we'll discuss our cases with an approach as to how to diagnose the cases and how to manage these cases. So coming on to our first case, this is a 34-year-old gentleman. He presented with around 2 into 3 centimeter hard node in left level 2 neck. He is a laborer by profession, resident of Mumbai. He has history of smoking for last 10-15 years. So coming to Ishwar sir, what would you ask the patient? What history would you like to elicit in this patient before proceeding for examination?
Smoking, alcohol, tobacco, because these are the carcinogens which lead to the things. In this present case scenario where you are talking, he is a smoker. So
Yes,
he is
sir.
more prone for carcinoma. So this predisposing factors or the etiology which is well established like smoking and alcohol. So this
Perfect.
should be inquired into, or
Yes, sir.
any oral submucous fibrosis, all that kind of history should be asked. In
Perfect.
the beginning, you said no history of previous malignancy.
Yes,
In
sir.
the last 5 years, I was referring to one of the book. Then he says that in last 5 years, there should not be any history of any previous malignancy. That
Yes,
is
sir.
also part of the definition.
Yes, sir.
Hmm.
Point well noted. So, extrapolating from that, so onset duration progression. One thing important to note over here is that the neck mass should be present for at least more than 2 weeks, and there should not be any sign of infection. Again, coming from Commerce criteria, there should not be any history of previous malignancy, as told by Ishwar sir. And there should be no definite symptoms related to a primary tumor. Dr. Karnika, what definite symptoms, what history would you ask the patient to rule out any history of any primary tumor which could point towards some kind of malignancy leading, causing this kind of neck mass?
So see, because this neck mass is in level 2, so I will I will take history regarding both oral cavity and oropharynx. So
Great.
the basic history starts with if there is any ulcer or growth that the patient feels, whether he is having any difficulty swallowing, chewing,
Great.
or while just swallowing saliva, or
Perfect.
any kind of pain which was not there before, any new onset symptoms basically.
Perfect.
This all we elicit from the patient. And breathing difficulty also we can take, but that is usually accompanied if there are other symptomatology as well.
Perfectly said, madam. And apart from this, there are some other histories which are, of course, more important in Western scenarios. But these histories also we'd like to elicit, which are sexual histories and the socioeconomic status of the patient, because they can also help us in reaching a conclusion in kind of a probable diagnosis about the lesion. Now, coming to
Ravi, in
yes, sir.
that the swelling is big in the HIV patient, the swelling which you, as compared to what is being mentioned in examination, that swelling is more cystic and more bigger. The nodes are bigger or the
Yes,
swelling
sir.
are.
Absolutely agreed. Absolutely. But for the completion's sake, I just mentioned that we should, while history, we should sexual history and socioeconomic status. So because this patient has a history of smoking and poor socioeconomic status, we can think of carcinoma in this kind of patients, which would be P16 negative.
Also, I would, because right now we have not labeled it as unknown primary. We
Agreed.
have all the differentials open. So the other differentials that we encounter in this age can be lymphoma, can be tuberculosis. So I always take history of fever, weight loss, and any B symptoms which are associated with lymphoma. So
Absolutely.
just complete the history part.
Perfect. Point well taken.
Uh,
So,
ill-fitting denture or difficulty in articulation or bleeding while brushing the teeth, all that kind of daily activity that should also be asked if there is any
yes, sir.
ulceration
Yes,
or
sir. Any sign symptoms which can point toward possibility of any other malignancy, we should rule out all those histories. So now coming on to examination. On examination, there is a hard mass at left level 2. There are no other significant findings. So Does this level 2 indicate to our any possibility? Will it help us in further examination or focusing our examination in any area? Anyone? Dr. Kanika?
Yeah, so the level of lymph node will give us a possible idea of the potential primary. For example, if I have a lymph node in level 2, then I will be focusing on oral cavity, oropharynx specifically.
Great.
Then if it is in level 3, level 2, 3, all, we look at the hypopharynx also.
Perfect.
Level 2 will also arise from nasopharynx. So it all depends on the site of the lymph node, which will give you a potential idea where all it can arise from.
Perfect. So
Tonsillolingual sulcus, base of tongue, and tonsil is this level 2 is known as node of tonsil.
perfect. So we have done a clinical examination. We have seen the level of the node. Now, what will be the next step? Now, what will be the next step which we will do in our OPD setting? Patient has come to us with left level 2 neck node. We have done examination, clinical examination. Now, what is the next step?
So for neck examination, per se, the most important thing to note is the your size. Size of the lymph node, then whether it is fixed to the adjacent structures, specifically skin, then mobility, which will denote whether there is any extranodal extension or not.
Okay.
If there is clinical extranodal extension, the stage is upstage.
Yes, ma'am.
Then after completing the neck, I would go for the potential primary sites. So a thorough evaluation of oral cavity, including all the subsites, oropharynx. Now in oropharynx, we have to visually examine as well as palpate, because base of tongue, some lesions are well appreciated on palpation. So we can examine and palpate tonsils, base of tongue. And then I would like to do a laryngoscopy, Hopkins, which will complete my loop of examining base of tongue, vallicula, larynx, and hypopharynx, and a nasal endoscopy simultaneously. So I will look into the nasal cavity and nasopharynx both. So this much I would do in the OPD itself.
So now we have done all these investigations, all these examination and clinical examination. Now, what shall be our next step? Shall we go ahead for an imaging, or shall we send the patient upfront for FNAC or biopsy, whatever we choose to go? We'll discuss about that. But first, we will send the patient for imaging or biopsy or FNAC. Ishwar sir?
I'll send for the radiology or in a CT or CT rather than FNAC, because that will upstage or it can lead to some intra-tumor hemorrhage. Again, it will upstage the tumor. So it is always better to do imaging first, then followed by some invasive investigation.
Great, sir. Perfect. Plus, imaging will also help us in localizing any putative or possible primary site, which can help us in identifying a possible site to do biopsy in further examinations. So one thing is important, that a PET scan is advisable, but many a times we do get patients who come with CT scan as the initial part of metastatic workup. So that is an acceptable modality until and unless we have done all endoscopic examination and ruled out all possible sites and no primary is found. So we can advise CT scan also as primary modality of investigation, but usually we should avoid doing it, and we should advise PET scan if we don't find any primary site on initial preliminary investigation. Now on imaging, we find this is the lesion. As we can see over here, there is a node on the right side, level 2. So what would be the next investigation? Shall we go ahead with FNAC or biopsy?
So have we done?
Biopsy will not be done. It's FNAC which will give you. We have to establish whether it is benign or malignant. Since we don't have any lesion, so it's better to go for FNAC.
Perfect. So FNAC you will do
ultrasound guided, or maybe if directly, if the pathologist is comfortable in hitting the lesion, so without ultrasound, depending
Dr. Kanika, you will advise FNAC or biopsy for this patient?
So we will do a FNAC.
Perfect.
But I would like to add a P16 stain to rule out any oropharyngeal primary. So for level 2 lymph nodes, we routinely do a P16 for unknown primaries. so that we
Great.
can narrow down our potential.
I'll come on to that, madam. I'll come on to that. So right now, all of us agree, the panel agrees that we'll first advise FNAC and we'll not go for upfront biopsy, right?
Yeah.
Great. So
Excuse
FNAC,
me.
Doctor,
Yeah,
Dr.
I'm Dr. Sharawat.
Yes,
So I would rather advise at least a true cut needle biopsy because in FNSC we may not be able to do any markers.
we'll
Say
come to
for
that, sir.
example, if finally we do not get an answer for primary site, at least this true cut needle biopsy in this we can study many markers,
I
immunohistochemistry markers.
I agree, sir. I'll come to that. Just let
Yeah.
me ask you to go. So, Dr. S.N. Singh, would you advise FNSC or would you advise a guided USG guided FNSC?
Again, what practice? Am I audible?
Yes, sir.
What practice we follow is like once are doing after CT, and we have got a clear-cut lymph node which can be approached directly, and if it is hard, then it can be done. FNAC can be done at minor OT or an OPD. But if we have got any doubt in that, it is better to go through a sound-guided FNAC. Because precision-wise, there are multiple factors which we plan how to approach a lesion from where negative NAC is minimized.
Great. So, what is the usual practice? Usually what you do in most of your cases are the USG
Most of the cases, it is USG guided FNAC to be safe because logistically, starting from logistically, patient visits us once and it is ready in few days. Subsequently, what we do is that we go for evaluation of the lymph node with high resolution probes, linear assay that's around more than 9 to 10 megahertz, and whereby we target the lesion. And there are multiple indicators like nodal and extranodal. Again, a nodal maybe see the focal or a diffuse cortical thickening from where we target the material, and some areas of necrosis whereby the periphery of the necrosis, which is vascular, we target there. Then subsequently medulla, again medulla we target, and we also try and see a lymph node whereby it is distorted. Distorted meaning the reniform shape is lost. It is a reniform shape. It's a bean-shaped lesion. The reni shape is lost. The size is increased. Okay, from reniform it becomes more or less oval. The size around 8 mm or 6 mm or 1 centimeter depends on the various criteria. However, we don't give much importance to size in this range. And thirdly, the hilar vascular supply, which is the normal lymph nodal vascular supply, is taken by a peripheral cortical vascular supply because the tumor of the metastatic thing outgrows its blood supply. So these are the indicators of lymph node being targeted, because at times your normal lymph node, a reactive lymph node also is targeted in case if it is not ultrasound guided.
Great.
So these are the things which helps us, as well as extranodal spread, or say the lymph node is as such the extranodal spread is involving an organ or a muscle or a vessel. So all those things helps us times matted lymph nodes indicating towards tuberculosis. So all that thing helps us to guide the treating physician into a certain.
Perfect. So basically, if it is ultrasound guided FNAC, it helps in increasing the chances of a positive result than a non-guided FNAC. Agreed?
Yes.
Yeah.
Great.
Also, the advantage of doing ultrasound guided FNAC is that if you have a good communication, good rapport with your intervention radiologist, we always ask them to just have a look on the contralateral side also.
Perfect.
Because sometimes this patient has just clinically presented to you. We have not done a PET scan yet or any imaging yet. Then the radiologist, they can sample the other side, screen it also. If they feel that there is anything suspicious there, they call us and they will do a FNA right there and then from the contralateral node also. And we have a bilateral positivity, which will change the stage.
Perfect. Perfect. So now coming on to Satyaveer sir. So sir, you have got an FNAC slide. How will you proceed? What stains or what approach will you take to diagnose this case? And what are the chances of it being malignant in your clinical practice, and what are the chances of it being benign?
Clinically, most of the nodes which are hard in consistency and somewhat fixed or immobile, uh, usually we do direct FNAC if it is hard and firm and fixed.
Okay,
And
sir.
we get sufficient amount of aspirate for
Great.
cytological examination. Number two, if the swelling is partly cystic or it is soft at some places, that means either there is some necrosis underlying or some cystic degeneration. In those cases, we always prefer to have ultrasound guided or guided FNAC. By after aspiration, the smears are stained and we can differentiate the lesion, whether it is benign or malignant. Most of the cases, in such cases, they are malignant, and squamous cell carcinoma is the most likely diagnosis in many cases.
Great.
The other thing is that if the lesion is cystic or has some necrosis, it's strong, and on cytology we find that it is malignant, it is squamous cell carcinoma. Partly cystic or degenerated lymph nodes in the level 2 level, cervical 2 level, they strongly suggest HPV connection.
Great.
So we always do P16 marker for the HPV confirmation, and that marker can be done by cell block preparation.
Great.
If it is fluid or necrotic, then we can have a cell block and P16 can be submitted for examination. This cystic or degenerative nodes strongly favor this HPV connection, human papillomavirus. Then, if it is not squamous cell carcinoma, we have to look for other kinds. Say it can be adenocarcinoma, it can be round cell carcinoma, neuroendocrine carcinoma, and it can be even lymphoma, as pointed out earlier. So, level 2 lymph nodes in the neck, oropharynx, most common site for primary, we have to look for.
Great.
And it has been found that in most of the cases, more than half even, more than 50%, the primary is located in the tonsils.
Great.
So we have to look for tonsils on the priority basis. Rest, second number पे आता है base of tongue, और third number पे आता है pariform fossa, posterior pharyngeal wall, then nasopharynx.
Agreed, sir. Point absolutely noted. So, suppose, sir, you have done FNAC, and this is the report, basic report which has been given. Now, Dr. Kanika, you get a report, this report stating true papillary configuration, monolayered sheets, singly dissociated atypical cells, anisonucleosis, internuclear grooves, internuclear inclusions. How would you approach?
So see, whenever there is a cystic lymph node, my DDs first are papillary thyroid cancer, cystic metastasis, and oropharyngeal carcinoma. Last, nasopharynx. So a cystic node always first I look at the thyroid.
Great, perfect. So what will be our next step in this kind of case? After this kind of report, Ishwar sir, what will be our next investigation in this kind of patient? We have gotten a report of metastatic papillary thyroid carcinoma. So this case was put to point out that not all isolated neck node metastasis, we should start thinking it as a squamous carcinoma. There is possibility of it being thyroid carcinomas, lymphomas, as stated by Dr. Kanika earlier. There can be any malignancies. And it is not uncommon to encounter papillary thyroid carcinoma which have metastasized to level 2 or level 3 with no identifiable thyroid lesions. So, what will be our next investigation in this kind of case?
So, in this, on FNA only, if you have clinical diagnosis, we can do ICC, we can put thyroglobulin stain, which will confirm it to be a metastatic thyroid. Then you do an ultrasound neck, look for a potential. If there are no lesions, still there can be microcarcinomas in thyroid.
Perfect.
You need a good high resolution ultrasound of the neck, and then the normal workup for thyroid, thyroid function.
And then we'll proceed as per the normal thyroid one.
Yeah.
Thank you. So now we'll proceed to our next case. So this patient is a 41-year-old gentleman, no comorbidities, reported with chief complaint of right neck swelling, approximately 2 into 2 centimeter for 1 month. He had no history of difficulty in swallowing and breathing. DL scopy was normal. Outside CT scan was suggestive of 2 into 2 centimeter neck node in level 2. No primary tumor was identified on any imaging or endoscopy. These are the imaging findings.
You said right neck swelling, and on imaging it is mentioned as left neck swelling, or is it the right only?
Is it right? It is right only, madam.
Okay.
So now the patient comes to our OPD with imaging and with FNSE, which shows positive for keratinizing squamous cell carcinoma. So what should be our next step with this kind of FNSE report? I'll go back to Satyavir sir.
Just to add to the previous case, if you have cystic or necrotic lymph nodes at level 2, most of the time we have seen that the aspirate which we get is dirty white or keratinous.
Okay.
Whereas in cases of thyroid papillary carcinoma metastasis, usually the lymph nodes are absolutely in parallel or at a same level of the thyroid gland, just lateral to the either of the lobes. It can be up, it can be down, but usually they are at the same level. And the aspirate which we get in papillary thyroid carcinomas, which is usually cystic, is absolutely characteristically brownish in color or dark brown or chocolate color.
Agreed.
That may be because of colloidal in that. So we can differentiate between the two characters of the cystic nodes or necrotic nodes, whether it is whitish or whether it is dark brown or tan color.
Agreed.
In papillary carcinoma thyroid,
Yes.
the nodes we have seen are almost in parallel or in line with the thyroid gland, and the aspirate is dark brown.
Okay.
And I don't think there is need of thyroglobulin for academic purposes. We can get it done. In cytology, we can absolutely be sure that it is papillary thyroid carcinoma. We find definitive papillae. We find nuclear characters, pseudonuclealization, nuclear grooving, and those thyroid follicles, and ovaling of the groups of the cells. There are so many features which can define that it is papillary carcinoma thyroid. In the end, we can get thyroglobulin done, and thyroglobulin can be done not only on the cell blocks, in the needle hub. If you range it with normal saline, and fluid thyroglobulin levels of that fluid can be done, and that will be raised. That will confirm the diagnosis.
True. Point well taken, sir. So in this case, this is the second case. In this case, sir, you have basically given us kind of a diagnosis of keratinizing squamous cell carcinoma. I'll go back to our to Ishwar sir. Sir, in this kind of report, would you advise P16 test or would you not advise P16 test to be done? Can we, so it's the patient has already had FNSE done from outside. A keratinizing squamous cell carcinoma report is there. CT scan has already been done. Would you want to get a P16 test mandatorily, or can you skip P16 test in this case? I'll also want to take opinion of Dr. Sneha on this.
Yeah,
Ishwar and
I'm
Sneha.
Dr. Shehrawat.
Ishwar sir and Dr. Sneha. Yes, sir.
Yeah, I'm Dr. Shehrawat. So
Yeah.
not only
This
P16.
P16, this thing we don't do in our practice. In MAMC, we don't do this. So I don't know about others, but in MAMC, it is not being practiced.
Great. Shehrawat sir,
Yeah. Am I audible?
Yes, sir.
So it is 100% mandatory to get HPV testing and Epstein-Barr virus testing, because the entire treatment prediction portal will depend on that. Number one. Number two, so can I see that CT scan slide? I think the node was on the left side and very
Yes,
big.
sir. Yes, sir. The CT scan is on the opposite side. I mentioned it
And
wrong
it
on.
is not, and it is very big. It is not just less than 2
I agree,
centimeters.
sir. But this is
Yeah,
for the discussion purposes only, sir.
not an issue, not an issue.
Yeah.
So we have to do HPV and Epstein-Barr virus testing both.
Great.
Without that, we should not proceed further.
So,
It is absolutely must.
even with a report of keratinizing SCC, will you mandatorily go for P16 positive and Epstein-Barr virus testing?
Yes. Because see, if it is oropharyngeal P16 positive, then we have to focus our fields on oropharyngeal region, especially tonsil and base of the tongue.
Mm-hmm.
And if it is Epstein-Barr virus positive, then nasopharynx is a very suspicious site.
Point.
And not only this P16 and Epstein-Barr virus, I think you will come in future slides, but we have to take a blind biopsy from ipsilateral tonsil and base of the tongue also,
I'll come to
if it
that.
is P16 positive.
I'll come to that, sir.
Yeah.
So, suppose as Ishwar sir said that we are not doing P. So at many centers, even in good oncological centers, P16 affordability for the patient does not have an affordability for P16. So in that scenario, how will you proceed?
You are asking me?
Yes, sir.
See, P16 is not very expensive. I think it is less than, I think, 2.5 to 3,000. So since it is going to change the entire management, I think we should not proceed without doing P16.
Okay.
Because if we do not do P16, then we have to cover the entire oropharyngeal, nasopharyngeal mucosa, which will lead to a lot of toxicity.
Yes, sir. Point well taken. So, so now we are clear that we have to mandatorily get P16. One very important thing is that P16 also helps us in prognostication, future data collection. It helps us in pointing out the site of primary, as sir has rightly said. If P16 is negative, we have to go ahead with EBV testing. One thing
Yes.
I wanted to discuss is that in keratinizing SCC, the chances of P16 and EBV positivity is very, very low. So usually P16 and EBV will present as non-keratinizing SCC and not as keratinizing SCC. Almost more than 95% of keratinizing SCC are P16 and HPV negative. So it is one scenario in where if the patient is logistically constrained and does not want to go, we can skip. But in that scenario, we might have to go for a larger volume or larger area of mucosal irradiation. Please, I would like your input, Sherawat sir, on this.
Yeah, I agree with you.
What is your experience, Dr. Sharawat? How many cases you see HPV positive?
Sir, whether we see or not, I mean, it is mandatory in today's times to do HPV and Epstein-Barr virus because it totally changes our radiation portals, and treating the entire nasopharynx versus only the oropharynx, it means a lot for patients' quality of life in future.
Great. So it is a very important point to note that in India, the overall prevalence of HPV positivity is not more than 20-25%. So overall, the patient profile that we see, the patients will have a history of smoking, patient will present in advanced stage. The nodes are not particularly that large and cystic. And usually our reports, they do come out to be keratinizing SCC. So our scenario usually is different as compared to the Western world. But as per the protocol and as per recommendation, we should definitely go ahead with P16 so that we can decide better about our mucosal radiation. So other thing, if it is P16 negative versus P16 positive, what will be your so I'll come to that question later on. Let us not debate from the topic. So what imaging modality would you advise, Dr. SN Singh, sir?
Yeah. So see, in either ways, as we discussed, it was PET CT, then CT, and again, depending on the logistics, in India, CT is what is done most of the time when the patient comes. So, for staging and localization, if these are the cross-section image, then we come to localization and characterization of the lymph node, whereby an ultrasound is the investigation of choice. Subsequently, SOS FNAC, which I've already discussed.
Great. Perfect. So now, as we have already discussed that based on these imaging modalities, we'll do endoscopic evaluation. During endoscopic evaluation, Dr. Kanika, will you go for blind biopsies? We have not been able to identify any primary based on our imaging. Will you go ahead with blind? Does anyone go for blind biopsies nowadays? Ishwar sir, Kanika ma'am.
So we go for biopsy of the tonsil or this thing as a this thing exercise the tonsil, send it for histopathology. But earlier it had been said that people used to do blind biopsy, malin slice biopsy of the nasopharynx, thinking it may be hidden somewhere in some crevice and you may take a biopsy. And it used to be done earlier, not now. Now with the endoscope, you can visualize and see the lesion very well. So blind biopsies, I doubt if anybody is doing nowadays.
Dr. Kanika, would you add any adjunct to help you during your endoscopy to take biopsy?
Kanika, you're muted.
Dr. Kanika, are you there?
She is muted.
Okay, yeah. So
Yeah.
NBI can be added. You can add narrowband imaging to help it narrow down. It can give you a better picture or a different light picture where abnormal areas can be again better perceived. But
Perfect.
it's not available everywhere. So narrowband imaging, if you have the filter for that, can be used to identify more abnormal area in a mucosa.
Perfect. Do you routinely do palatine tonsillectomy?
So our institutional practice is not to, matlab, we generally do PET guided biopsies only if we have a cross sectional imaging. Yeah, it's there in the guidelines to do palatine tonsillectomy also, but as an institute we are not following it.
Perfect.
Like
Does sir or Dr. Kanika or Dr. Ishwar, does anyone follow carpet resection?
mucosectomy, you mean?
No. So the
No.
point where I am coming to. So there is a lot of evidence or data from Western literature which talks about tonsillectomies and carpet resection, but we are not doing it in our scenario in our country because all these are Western data which are mainly dictated by P16 positivity. So in scenarios where the disease is mainly P16 driven, those cases they have higher chances of getting a positive biopsy result with carpet resection or tonsillectomy. In our country, where the incidence of P16 is really low, these tonsillectomies and blind biopsies are usually not done. Please correct me if, or please, any input is welcome. Dr. Kanika, Dr. Ishwar, Dr. Shay Rawat, please.
Yeah, so same thing. As an institute, we are not doing it. Also, for tonsil, we know that the incidence of contralateral neck metastasis is also high. So, just doing an ipsilateral tonsillectomy, sometimes you may still miss the primary. So, right now we are just doing if there is any abnormal PET uptake or something.
Perfect.
But it's there in the ASCO guidelines, all the European guidelines. It says to do.
But in our Indian scenario, we are not doing it. So I just want to give this message loud and clear that it is not mandatory in our India scenario because we have data to say that the incidence of HPV positivity in our scenario is less. Though Western guidelines, NCCN guidelines, all those guidelines, they do say and emphasize on this, but it is not being widely practiced in our part of the world. So now I'll recapitulate this case. It was 2 into 2 centimeter lesion, the left side of the neck. All investigations are negative. P16 is negative. It was keratinizing SCC. What is the next step? Radiation versus surgery. Ishwar sir.
I go for surgery. You should do at least extended supraomoid neck dissection.
Perfect. Shay Rawat sir. Dr.
I
Shay Rawat.
completely agree. I completely agree. We should go ahead with surgery upfront, and because it will also give us a lot of further details, what kind of grade was there, whether there was extra capsular spread or not, and many other things. So we can decide the dose of radiation, whether we need to add chemotherapy. So first of all, we should go for surgery.
Perfect. So, point well taken. So, if it is a very small node, 2 into 2 centimeter, imaging is showing that there is no extra capsule extension. We think we can come out with a nice dissection, complete, good quality dissection. That is the scenario where we should go ahead with neck dissection and not radiation as the primary modality of treatment. In this scenario, would you advise adjuvant radiation post neck dissection where it comes out to be single node 2 into 2 centimeter positive for metastasis, no ENE? Dr. Shehrawat.
Yes, definitely we have to irradiate. And here comes a question whether we should irradiate only the oropharyngeal part, thinking it to be oropharyngeal, or we take the other mucosal sites also covering some part of the nasopharyngeal mucosa also. So
Great.
there is no doubt that we can omit radiation. We have to give radiation. Of course, in this case, we will give only radiation. We won't add concomitant chemotherapy.
Great. So there is data also to say that when you have a single positive node without any external extension, we have a high quality neck dissection, which means that we have more than 18 lymph nodes dissected with a proper selective neck dissection. In those cases, adjuvant radiotherapy can be skipped. Okay. Dr. Sreenawat, if we are giving radiation, what
Yes.
would be your radiation field? Will you give a selective radiotherapy or will you give a comprehensive radiotherapy with a single ipsilateral neck node positive, no external extension, 2 into 10 2 centimeter node?
So if we have not been able to identify HPV positivity or EBV positivity, in that situation, we have to cover the entire entire mucosa extending from nasopharynx to oropharynx and hypopharynx. Only thing is that we will be able to spare larynx. We will be able to give lesser dose to the nasopharynx because it is level 2 node. So we will definitely give more dose to the oropharyngeal mucosa and lesser dose to the nasopharyngeal and hypopharyngeal and laryngeal mucosa. But
Great.
we have to cover all the sites.
Great. So, absolutely agreed. So there are multiple varied practices being done at different centers. Now the treatment line is evolving towards it is going towards less aggressive treatment line and less of pan-mucosal radiation kind of scenario. As sir has rightly said, that if we do not have all this reports pointing towards any particular site, in those cases we might have to go ahead with a greater site of a greater field of radiation. Great. Now coming on to our third case. He's a 62-year-old male patient, nil comorbidities. He reported with swelling in neck on left side for 1 month. He has history of gradual progression in size of node with no associated tenderness. Multiple cervical lymph nodes on left side, 5 into 3 centimeter largest node. No suspicious growth in oral cavity or oropharynx. DL scopy, upper GI scopy, nasal endoscopy normal. FNAC comes out to be non-keratinizing FCC. Now what we will do? The last case was keratinizing FCC, where we thought that, okay, we can proceed without P16 or EBV. This is a non-keratinizing FCC. Ishwar sir.
As we discussed earlier, get the HPV 16 for this case.
Great. So this is the scenario where we will like to go ahead with a mandatorily a P16 test. Okay. So in this patient, the P16 was positive. PET CT was suggestive of the lesion as defined. So in this case, Dr. Kanika and Dr. Shehrawat, what shall we go ahead with?
So
Surgery
this
or
is
radiation?
a direct chemoradiation patient. I don't think there is any role of surgery in this. The basic aim is that patient should either have minimum modality treatment. Now that we know this patient has extranodal extension, so he will need chemoradiation. So there is no point of adding surgery and make it triple modality. Better let it stay double modality. So in some cases, I will not do surgery, just chemoradiation upfront.
Perfect. Point well taken. So surgery has the disadvantage over here of extensive resection, need for post-operative adjuvant treatment. The patient will go for triple modality treatment, as Madam has rightly said, and it will lead to triple modality treatment toxicity. And surgery will also not help us in addressing the putative mucosal sites, which radiation will help us in addressing. So Dr. Shehrawat, what will you do in this patient? Unilateral or bilateral radiation?
Well, this is a very extensive disease. In this, we have to do bilateral radiation along with concomitant chemotherapy.
Great, agreed. Uh, what will be the mucosal fields you will address in this kind of case?
Right from nasopharyngeal to hypopharyngeal and in laryngeal mucosa.
Great.
And we'll try to minimize dose to the larynx, parotids.
So this was P16 positive. Will you cover
Okay, this
laryngeal
was
mucosa as
P16
well?
positive.
Yes, sir.
Okay. I didn't note that. So if it is P16 positive, then I will definitely not irradiate the nasopharynx.
Great.
And skipping the nasopharynx and part of oral cavity, anterior oral cavity, we will irradiate the entire oropharyngeal mucosa
Yes, sir.
and protect larynx also.
Yes. So point well taken. Where P16 positivity is proven, we will not radiate all other parts of the mucosa. We will radiate only the oropharynx. We will also try to preserve hypopharynx and laryngeal mucosa. It will help us
Yes.
in better toxicity management and reduce toxicity profile for the patient. How will you follow up this patient in long term?
So
Dr.
We
we
will
Sita,
do,
follow it up with PET scan after 3 months.
after 3 months, you will follow it with the PET scan. Great. And after that, you will follow the
And
normal.
a routine clinical examination at every visit.
Great. Point well
so
taken.
I would add something to it.
Yes.
I would keep examining the patient on monthly basis, and if at about 8 to 10 weeks, I feel that the nodes are still very hard, and unlike to I show complete response at 3 months, then maybe we can evaluate earlier some imaging and subject for salvage neck dissection sent to the oncosurgeon for that
Perfect. Point well noted. So if
instead of waiting for 3 months.
perfect. So if after chemoradiotherapy we see that the node is not responding, we can assess. So what duration will you wait for reassessing the patient?
If there is a good response clinically, then maybe 10 to 12 weeks. If there is a poor response, then maybe as early as 8 to 10 weeks,
Great. Okay,
so
point
that
well.
the treatment is not delayed.
Great. So that early intervention and salvage surgery is not delayed.
Yeah.
Now coming on to our last topic for the day, last case for the day. He's a 47-year-old male patient, nil comorbidities. He had history of gradual progression in nodal mass with slight dysphagia, no breathing difficulty. Clinical examination revealed two bulky nodes 4 into 4 centimeter, approximately firm, non-tender bilateral neck lesion, level 2 and 5. Overlying skin is free. No primary lesion in oral cavity or oropharynx. Triple endoscopy was normal. PET-CT scan also showed bilateral level 2 and level 5 neck nodes, 5 into 5, around 5 into 3 centimeter, abutting SCM, no primary lesion identified. This was the imaging. FNSE was suggestive of poorly differentiated carcinoma. What will be our next step in this patient? What IHCs will we advise in this patient? Satyaveer sir.
Because it is poorly differentiated and the level is too below in the neck, we have to look for infraclavicular primaries. And that will include breast, GI tract, kidneys, and genitourinary tract. And correspondingly, by seeing the morphology of the cytomorphology or histopathology of the lesion, we can decide whether it is RCC or whether it is breast carcinoma, and accordingly we can get the IHCs done.
Perfect, sir. So this was level 2 and level 5 neck node. IHC which was advised from our end was P16 and EBV. P16 was negative and it was EBV positive. So after this, what will be our treatment plan? Coming to Sher sir, is there any indication and role of neoadjuvant chemotherapy in these cases?
Yes, nasopharyngeal carcinoma of this stage is one site where we will start with chemotherapy upfront, and after completion of chemotherapy, we will give concomitant chemoradiation. So there are two schools of thoughts. Earlier, we used to give chemoradiation followed by adjuvant cycles of chemotherapy, and later on, neoadjuvant chemotherapy followed by chemoradiation. So this keeps on fluctuating, but with such extensive nodes, when expecting very huge radiation portals, radiation fields, I usually prefer neoadjuvant chemotherapy first, followed by concomitant chemoradiation.
And apart from this case, sir, what will be your indication for advising neoadjuvant chemotherapy in isolated neck nodal metastasis cases? Leaving this case aside, what indications
Okay.
take for neoadjuvant chemotherapy for isolated neck nodal metastasis?
Yeah. So as such, if we see the guidelines, it comes in level 3 neoadjuvant chemotherapy. But in any case, sometimes if we feel that patient is too morbid to, or the field may be very huge, radiation portal may be very huge, which will increase the morbidity. In such cases, on case-to-case basis, customization, we can give neoadjuvant chemotherapy so as to shrink the tumor volume and then go on with chemoradiation.
Great. Dr. Kanika, how do you decide between surgery versus radiation for carcinoma unknown primary cases? This is kind of a summary discussion which we are conducting, so you can summarize your treatment decision making.
So surgery we generally reserve for N1 disease, single node and small node. Basically, I want a single modality treatment. So
Perfect.
if there is any indication where the patient has to receive chemoradiation or adjuvant radiation, then I would rather delete surgery and send the patient directly for radiation therapy.
Great.
So single node less than 3 centimeter, no extra nodal extension clinically or radiologically.
So any disease which is more than single node, that goes for chemotherapy and radiation upfront, correct?
Yeah.
Any disease where the nodes are bulky and the portal of radiation is going to be huge, it goes for neoadjuvant chemotherapy, correct?
Yeah. So I would give neoadjuvant if they are low level nodes. I am more worried about like level 4, level 5 lymph nodes. I'm more worried about patient having distant metastasis, or if the nodes are big enough that they may cause a potential airway compromise later on. Sometimes we have huge level 2, 3 nodes which will start pressing to the airway. So to reduce the size and so that the patient can easily undergo radiation later on, in these cases only, and nasopharynx where CT is well established nowadays.
Now, Sherawat sir, this case, bilateral level 2 and level 5 neck nodes, positive for EBV, what will be your portal of radiation?
Well, it goes without saying that we have to treat it as a nasopharynx, not proved otherwise, but EBV is there. So we have to cover the entire mucosa from nasopharynx. And since the nodes are covering level 4 also, so we have to go down and up to hypopharynx also, sparing the larynx.
Perfect. So, just one more question from you. I just want you to summarize your treatment decision making and mucosal fields which you radiate on different stage wise, and your clinical decision making, that how do you decide what mucosal fields you will radiate, what levels will you radiate?
Yeah. So the treatment will essentially depend upon HPV and EBV positivity or negativity, because they will largely define our portals. If it is EBV positive, then we have to go as high as nasopharynx. If it is HPV positive, then we have to focus our portals largely on oropharynx. And this also covers the mucosal fields and the areas of, and if we treat the high risk areas, say for example in nasopharynx, will be the nasopharyngeal mucosa. There we will give dose as high as 70 gray, minimum 66 gray in 33 fractions to 70 gray in 35 fractions. And the low risk areas where there are no nodes, but there are potential for metastasis, there we will give minimum 55 to 56 gray. That's it.
Great. So one more question. Suppose there is small 2 into 2 centimeter N1 node, patient does not want surgery. What will be your portal of radiation and what will you radiate single neck? Will you radiate both the necks? And how will you decide your radiation fields in it?
Yeah, ipsilateral N1 node, ipsilateral N1 disease.
Yes, sir.
So we will irradiate only the ipsilateral neck, and we will irradiate level. This is if it is level 2 node, then
Level
one
2.
station ahead. That means level 1B, level 2, 3, 4, and part of level 5.
Great.
This will be within my radiation portal. The dose will be differential. Nowadays we have IMRT technique, so we can give differential delivery of radiation dose to the main area, means the level 2 node plus one station above and below. We will give a higher dose of maybe 66 to 70 gray, and the posterior neck and lower neck we will give lesser dose, maybe 60 gray.
Great.
Sir, I have a question for Dr.
Yeah.
Shairawat.
Yes.
So, sir, now that we know that nasopharynx is quite endemic, like nasopharyngeal CA, and we in our experience we see it mostly in northeast part of our country, and not.
Yes.
So, then do you ever decide based on patient demographics, the ordering of EBV, DNA, or EBR on node, or is it like for all patients? I want to know your experience. That do you see it outside of northeastern community?
So as I told you, I never start treatment of a patient with primary occulta secondary neck without doing HPV and Epstein-Barr virus, because sometimes you may land in big trouble. And as you said that it is endemic in northeastern part. So if you have a northeastern region patient, definitely no one should go ahead without doing Epstein-Barr testing. And yes, you have a very good point. Since it is more common in northeastern region, in those cases, we have to individualize and treat the nasopharyngeal area if we do not have these reports.
Great.
Okay, sir.
Great. Point well noted. So, to kind of summarize, sorry. So, on clinical examination and based on our clinical history and examination, if we find a primary lesion, nothing like it, for a nodal metastasis, our disease management will go in that direction. But if we don't find a primary lesion, in that scenario, as discussed, and Dr. SN Singh will second me on this, we'll go ahead with USG guided FNSC. USG guided FNSC, if it is negative, we'll keep the patient on follow-up or maybe a repeat USG guided FNAC if high index of suspicion. Non-diagnostic, in those cases, we can go ahead with core biopsy or repeat FNAC if it is positive for malignancy. And in that cases, we have to look what kind of malignancy. It could be thyroid cancer, it could be suggestive of melanoma, adenocarcinoma. If we have ruled all this investigation, because if it comes out to be thyroid, metastatic thyroid carcinoma or melanoma, then it does not fall under the criteria of carcinoma unknown primary. Then it is to be treated as the primary malignancy of thyroid with a metastatic neck node. So now if it comes out to be squamous cell carcinoma, then based on our squamous cell carcinoma, as we have discussed, if it is single node, we are 2 into 2 centimeters small. The aim of our treatment is to reduce the modalities of treatment in order to reduce the toxicity, as we have, because we know that dual modality treatment also gives good oncological cure with reduced functional morbidity. So if we have a single node, metastatic node, we'll go ahead with comprehensive, selective neck dissection, at least covering level 1 to 4 if it is level 2 node, or level 1 to 5. If it is more than 2 centimeters, suspicion of ENE, where chances of adding adjuvant chemotherapy and radiation is higher after surgery, we'll send the patient for upfront chemo radiation. The portal of radiation will be decided and will be finalized after discussion with the radiation oncologist. It could be unilateral, it could be bilateral. We can involve the mucosal sites based on a multiple investigation factors as we have discussed. And if after a radiation, if there is a large volume disease, if after chemo radiation, the disease does not involute there is a residual disease, then we can think of salvage resection in those cases. Thank you so much for your patience. Thank you to all the panelists. I hope the discussion was interesting, and all the students who have joined today, they had something to gain from the discussion. Thank you so much.
Thank you, sir.
Thank you.
So we have some queries in the chat box, if you could answer that. So,
Hello.
How do
hello.
we answer the chat
Hello.
box?
Hello.
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 Dr. Raman, Dr. Manish here. So,
हाँ
good,
जी,
eve-
good evening, good evening.
good evening, everyone. So, can I ask one or two questions?
Sure, sure.
So, my first question is actually, in case say it's discussed this FNAC and core needle biopsy. So, I strongly recommend core needle biopsy, and it has been many times proved by the MD Anderson and ESMO guidelines that a core needle biopsy has 80 to 90% sensitivity. So I highly recommend that all the head and neck surgeons should go core needle biopsy because it helps in ISC imaging, it helps in molecular profiling of the patient, and it helps in NSG, which can define the further chemotherapy module. So I don't think nowadays, because most of the FNEC are showing poorly differentiated carcinoma, that has nothing to do with the patient. Means we cannot do the further treatment of the patient. If you go for RT, that is okay. Definitive CT-RT is okay, an option, but you should definitely go for core needle biopsy. It's a OPD procedure. Nothing much more time needed for that. So, and it's actually proven by ESMO. It's written clearly by NCCN guidelines that you have to do core needle biopsy. It's preferred and over FNAC. It's clearly mentioned. This line is clearly mentioned in ESMO guidelines and NCCN guidelines. My second point is that regarding NACT for the cup. So NACT, as per ESMO guidelines 2024-25, there is no role of NACT in cup patients. So second thing is, yes, this NACT has many things to do with the patient. So sometimes people used to give NACT in this patient because NACT, generally there is no standard treatment, but you can give in N2C node, N3 node. Yes, you can give in heavy nodal burden with carotid encasement and all these patients. Yes, it will reduce the burden of that node. So RT planning will be good for these patients. But as per guidelines, there is no role of NACT in cup patients. So these are my 2 points. I think this should be taken. Or sir, what's your opinion? Like I would like to ask with Iswar sir and others sir.
Yeah, may I speak? Dr. Mahesh, I'm Dr. Sharaf. I completely agree with your first point that we should go ahead with a core needle biopsy rather than FNAC. Because quite often on FNAC, we do not get adequate information. Even I was pitching for that only. And number two, NACT, I told it is, sometimes we have to individualize depending upon if the portal, as you rightly said, if the radiation oncologist feels that field may be too big for patient to tolerate. Only in that scenario, otherwise that is not the treatment of choice. You are right.
Yes, and my third question is my third point I would like to ask that yes, might be it has not been discussed in this today's evening topic that TORS. Yes, TORS is also having some role in cup. It has diagnostic and therapeutic role also. Transoral robotic surgery. So we can do in cup patients having with like suspicious of bilateral tonsillar involvement or cup that base of tongue involvement. So we can do in early T1, T2 lesion TORS. It is diagnostic also and therapeutic also. So I think
We do
this
not have
topic.
a T1 or T2 lesion.
Yeah,
It is a case of
it is
primary
the
unknown.
Yes, yes. But in case like I had already like.
No, we
So
are talking of primary unknown.
one more point which I want to add. I absolutely agree that core biopsy is the investigation to be done when we are thinking that we have to get more tissue for P16 and other ISC analysis. But we have to look at from this perspective that the patient is walking to our clinic. We don't have a diagnosis of carcinoma unknown primary right now. It could be lymphoma. It could be metastatic thyroid cancer. It could be tuberculous lymphadenitis. It could be non-specific inflammation. And if we see, so until unless you are working in an apex cancer center where most of the patients are referred, they will already be having a diagnosis of FNSC, which is proven to be carcinoma. But if you're working in a clinic, there's a very high likelihood of patient who will be walking in with tubercular lymphadenitis. The patient might be walking in with thyroid lymphoid tissue. So if on clinical examination, you are sure that this is malignant lesion, most likely carcinoma, squamous carcinoma, go ahead with core biopsy. But if there is any iota of doubt, I'll like to go ahead with FNSC for those kind of lesions.
Yes, sir, I definitely agree with this point, but there is the preliminary like investigations like USG and CT are they are not so much like costly, or they are not so much like inaccessible things that can't be done. So a single ultrasound can detect, sir, whether it's a hemorrhagic, it's adenocarcinoma, or they can give a clue to you, sir.
Absolutely,
So we
absolutely.
can
Your point is
we can go for a preliminary ultrasound. That is more than sufficient. So
absolutely.
after
So
that we can go for core biopsy. I'm not saying that directly go for core biopsy. No,
absolutely agree. Your
first do
point is right.
radiological imaging. If yes, if CT is not possible, go for just simple ultrasound. That is more than enough. That ultrasound can give you the clue, the capsular invasion, the cystic, whether it's cystic solid, means many characteristics are done by a good ultrasound. So that is more than sufficient to define whether it's a occult primary or cup, or whether it's some other like malignancy, or it's a lymphoma. Or
Agreed.
if it's still not possible, then go for CT. That is also like available like in every, I think, center, at every place. I think CT is not so much like PET scan, that it is not available in each and every state or centers.
Agreed. Point well taken.
I think we can end the discussion here, sir. Thank you, everyone. I thank all the panelists for taking out their precious time and giving their inputs on this topic. And thank you very much, sir, Ravi sir, for
Sir, एक मिनट
agreeing and to be part of this session. So now I invite Dr. Ravinder Gera sir, who is the president of Haryana AOI, for the final comments.
Dr. Raman,
Hanji sir, Rupinder sir.
Dr.
Sir,
Sapir.
एक मिनट.
Hanji sir.
The discussion was about core biopsy and FNSC.
Yes, sir.
In peripheral centers, tertiary center, rather more than tertiary centers जहाँ पे हम काम कर रहे हैं, core biopsies are not usually done. We always do FNSC first, and we have seen ultrasonographically or radiologically proven lesions, almost proven lesions, that it is benign or it is malignant, and we do FNSC. It turns out to be absolutely different. We have reported benign memory lesions on ultrasound, and we did FNSC, turned out to be carcinomas. So there is a much discrepancy. And in peripheral centers, we always prefer to do FNSC. Many lesions, 90% of the cervical nodes in our setup are tubercular or infective. Highly, there is the incidence is increasing, but most of them are benign or infective. So it is better to have FNSC done first. It takes hardly 1 hour or 2 hours to report it. It is absolutely non-invasive. In core biopsy, we have to wait for 5-6 days for reporting. So it is not harmful to get a FNSC done and then do a core biopsy. In higher centers where the patients go, FNSC, most of the cases already have undergone FNSCs. So they usually do the core biopsy. That was my point.
Agreed, sir. Point
Thank you, sir.
absolutely well taken.
One point. Even in MAMC, we do FNAC only. MAMC is a tertiary care, but it's just like civil hospital. We get almost 1,000 patients or 800 patients. So it is difficult to go and do the core biopsy. It has to be done by, if the pathologist help in doing it, then it will be great. Otherwise, catering to that number and then going and doing the biopsy, it will be difficult, sir.
One point which is important to understand, that core biopsy is kind of mandatorily required to do IHC analysis. In our setting, Why are we looking for IHC assessment? IHC is being done to look for P16 or EBV positivity. In our setting, in our clinical scenario, the incidence of P16 and EBV positivity is not really very high. It is all Western data. In our data says that Indian data says that our incidence of HPV positivity does not extend more than 20-25%. So almost 80 to 85% of our patients will not require IHC, or they do not mandatorily require IHC analysis to confirm the diagnosis. That is one point which I wanted to make. Please correct me if I am wrong. Ishwar sir.
Agree, because we are just banking on the Western data. We don't have our own data. Otherwise, that will set our own and this thing protocol and what should be done. We are having the maximum number of oral cavity malignancy. We should have our own protocols.
Dr. Kanika, I'll also like your input before we close. What are you practicing in your clinical practice? Are you doing core biopsy for all the walk-in patients, or do you do core biopsy after the patient has come to you with FNAC report suggestive of squamous cell carcinoma?
No, generally we go for with FNAC only. And what I have seen is if your cytology department is good, most of the times we have a good cytology report. So the diagnosis is confirmed. Only if in rare scenario, if the cytology report is not conclusive, then only we go for core biopsy.
Great. Okay,
Just to add one point.
So can I tell one thing? Actually, okay, if you do FNAC and it shows poorly differentiated carcinoma, so what will be your plan?
So sometimes if
And
the
most of the
cytologist,
okay,
they can make a cell block also. Then they can
yes,
put epithelial markers like CK.
yes,
So
yes,
then also you can establish that this carcinoma is of epithelial origin,
yes,
likely squamous cell carcinoma. So
yes.
we discuss in our tumor board if and then the radiation oncologist also like everybody sits. And if there is any doubt that on FNAC we are not sure that it is from the head and neck origin, then only core biopsy.
So
But
see,
that scenario is very less.
so see, it's all actually three things. It can make you uh, to take a chemo radiation. Okay, one thing. Second thing, it can make you HPV positive or not. IHC marker, all the IHC marker, whether it's cytokeratin or any other marker. So that my mainly focus for the core biopsy is that, because after poorly differentiated carcinoma you cannot do anything. If you are going for any CRT or concomitant chemoradiotherapy, it doesn't solve the problem, because it might be anything. So
So what is your what it could be? If
so
it is
so
not a squamous cell, what are your then I
it
will
can
look
be
at what are my potential
so it can be adenocarcinoma, it can be some salivary gland. So the thing is that if you have the diagnosis of cup in your mind, now I'm not telling about some lymph node or some cystic swelling or some tubercular. Just go for a simple ultrasound, and if they are suggestive of that it's a metastatic uh, or CUP, then directly go for core biopsy. My thing is that it will solve your three problems. It can help in next generation sequencing also, that what chemo radiotherapy you are planning.
So I am also agreeing with you. It's just that the question was when the patient first comes to your clinic, what
Yes.
investigation you are going to give.
So see,
for me, I would still opt for an FNAC, a lesser invasive procedure as compared to TrueCut, and I would definitely go for core biopsy if I am not sure of the diagnosis on FNAC. So
yeah, definitely.
I would
Agreed.
not prefer two investigations, but I would always go for a lesser invasive test.
Actually,
first.
both are
I
invasive
think
procedure. That FNAC and core
Agreed.
biopsy both are
So
invasive
I
procedure.
think we
Dr.
get the gist
Manish,
of it.
yes,
We get
yes.
the gist of it. So definitely core biopsy is the confirmatory investigation in case of any doubt, and it really helps us in solving a lot of questions. And one point which you said was absolutely correct, that it can help us in next gen sequencing also. But usually what we are practicing right now in our clinics is that not all patients walking into the clinic are malignancies, first of all. Most of the patients are maybe tuberculous or benign lesions. So based on that data, we are preferring to go ahead with FNAC. FNAC also gives us a very fair idea of what the disease could be. Many a times IHCs could be performed on FNACs also. I agree, EBV and those IHCs, it is very difficult to perform on FNAC. But as a preliminary investigation, FNAC is not a poor choice. Not all patients mandatorily need to go with core biopsy, but yes, core biopsy does help in confirming the diagnosis and helping with further line of treatment.
Ravi, is there any scope for open biopsy?
Sir, open biopsy is to be done only if we are suspecting it to be lymphoproliferative disorder, or we do not get any kind of diagnosis on FNAC or core biopsy. That is the only indication for open biopsy. Otherwise, open biopsy is absolutely contraindicated.
Yes, I agree to you.
Yes, sir. So,
yeah.
Yes,
So,
is there any concluding remarks, or we have already overshot the time.
Overshot the time, yes. I
Yes.
think we can conclude here.
Yes, sir.
Dr. Gera wants to say something.
Yeah, so I really thanks the moderator, Dr. Ravi Shankar, for the wonderful moderation.
Thank you, sir.
And I thank you, Dr. Ishwar Singh, for being